Assalamu alaikum. I'm Dr. Nisar Akbar Khan. Today we are going to have a look on congenital anomalies of external ear. Bat ear. Bat ears. Sometimes you might have seen children suffering from bat ear. Bat ears are actually abnormally protruding ear. Here concha is large. It is because of poorly developed antihelix and scapha. Surgical correction is done after 6 years of age. These are bat ears, large protruding ears. Here in this diagram you can see antihelix. This is the normal picture. This is in comparison with the bat ear. Antihelix is absent and concha is excessively large. What we do is, behind the ear on its medial surface, we apply multiple sutures actually that helps in developing antihelix, and that results in decreased protrusion and the creation of concha. Pre-auricular appendages. Supernumerary auricular hillocks, skin-covered tags. They lie in a line between tragus and angle of mouth. They are usually of no significance and they usually do not require any surgery. But if patient wants to go for cosmetic correction, we may perform it. This is a pre-auricular appendage accessory appendage of ear. Pre-auricular sinus, seen commonly at the root of helix. Please mind it, the commonest congenital anomaly of external ear with which patients usually present to ENT surgeon is pre-auricular sinus. It is because of incomplete fusion of auricular tubercles of first and second branchial arches. Patient presents usually with discharging sinus. His main concern is repeated infections. Sometimes if the ostium of the sinus gets blocked, there may be abscess formation. In that case, patient will present to us with fever and severe pain because of stretching of the overlying skin. Surgical correction, excision of the whole tract of the sinus is the treatment of choice. Here you can see this is a pre-auricular sinus. The sinus lies at the root of the helix. This is another patient which presented with pre-auricular sinus abscess formation. You can see the stretched shiny skin, redness, all signs of acute inflammation, swelling, all signs of abscess. So in this case, first it has to be incised and drained, and later on surgery will be performed. Anoxia is complete absence of pinna. Sometimes it is a component of first arch syndrome, which includes Treacher-Collins syndrome, mandibular dysostosis, and Pierre-Robin syndrome. Microtia, as the name indicates, is a smaller ear, smaller than the normal ear. It may be associated with other anomalies such as atresia of external canal or middle ear abnormalities. It may be unilateral or bilateral. Patient presents with cosmetic deformity and with hearing loss. This is grading system of microtia. Complete absence of external ear, that is pinna and external canal, is anoxia. This is grade 1, smaller than normal. All the structures are normal. Ear is distinguishable. Here in grade 2, parts of the ear look normal. Usually the lower half, the canal may be normal, small or completely closed. Grade 3, just small remnant of peanut shaped skin and cartilage. This is common. There is no canal, which is called oral atresia. So this is staging of microtia. The last and grade 4 is anoxia. Treatment may be rib cartilage reconstruction. This is performed at 2 stages. In first stage, graft from the costal cartilage is excised, is harvested, and is placed behind the pinna in the mastoid region. It causes stretching of the skin, and later on, when there is enough skin is available, that skin and cartilage is used to give convolutions to the external ear in the second stage. Another is prosthetic implant reconstruction. Atresia of external auditory canal may patient present with alone or with microtia. Failure of canalization of ectodermal core that fills the dorsal part of first branchial cleft results in formation of atresia. Outer meatus may be filled by fibrous tissue. Deeper meatus may be involved, but TM joint is normal. With microtia, it may present with microtia and other anomalies. Here you can see pinna seems to be normal, but external aortic canal is obliterated, is atretic. No lumen is visible over here. Collaural fistula. This is also called first arch fistula, anomaly of the first branchial cleft. Fistula has got two openings. The opening one first opening is situated just below and behind the angle of mandible, while the second opening is in the external aortic canal. Trachofistula passes through the parotid close to the facial nerve, so an axial facial nerve can get damaged. This is a collaural fistula. In case of second branchial cleft fistula, the internal opening lies in the tonsillar fossa, while in case of third branchial fistula, internal opening lies in the piriform fossa. But this is first branchial cleft fistula. In this, the internal opening lies in the external aortic canal or sometimes in the middle ear.